We've just conducted a trial that shows that geriatric assessment can improve communication about age-related concerns between oncologists, older patients with cancer, and their caregivers. This was a large cluster randomized trial done in the University of Rochester NCI Community Oncology Research Program Network that enrolled 542 patients. These are patients that are normally not included on clinical trials because they have other medical problems. We were, however, able to recruit them to this trial because the question was clinically important to them. What we found was geriatric assessment improved communication by increasing the number of discussions about age-related concerns and also by improving quality of that conversation and oncologists discussed more interventions that could be applicable to older patients with cancer and their caregivers.
What happened in that study is that they had at least 2 topics that were addressed in the intervention group about these geriatric problems that would not have been addressed otherwise. And not only were they addressed, but they generated an intervention. And I think that's where the proof of the effectiveness is. A critique that people have done a lot of times to geriatric oncologists is, this is great, this is dandy, but I'm a busy oncologist, I don't have the time for that. Well, in this study, like in others, in a quarter of patients you modify cancer treatment, and in this particular study you had 2 points that the patient had recognized as modifying their treatment and improving their quality of life. So this study really shows something that the patient feels at the end and is a difference between the 2 arms of the study.
It's important because oftentimes we only think about things like performance status. By doing a geriatric assessment, we also look at things like cognitive function. We look at things like performance status, their ability to do things, their need for assistance. It could be really important because if we know they have a cognitive impairment, we may not want to give them pills that they have to remember to take. If we find out that they have problems getting around and with mobility, we may not want to give them a chemotherapy that might further limit that sort of ability to be up and around. And so this is an important study because it shows that in a pretty quick period of time, the staff involvement was about 10 minutes, we can get information that we can use in a very important way to treat these patients.
It'll change practice because it brings up issues for older adults that can affect their overall care, including their care for their cancer. They could be more adherent with the treatments if we're known about the consequences that they're having. It could also change the way we decide to treat them with higher doses or lower doses of medicine based on whether they have issues on the geriatric assessment.
My recommendation would be try it. There are many tools available, some very simple that your staff can do, that you can have your patient fill, and just look at it. And that, just by itself, of knowing the information, you are going to act upon it. And try it first with a few of your patients. And geriatric oncology is really one of these things that grows on you. And the more you do it, the more you want to do it, because the more you realize how much it helps with your care.
I think it's important to realize that it's a pretty minimal amount of time, and that 10 minutes of time that we may be using to more effectively learn about our patients may save a lot of time later in terms of managing their side effects or being able to sort of get them the effective therapy they need.
This is why geriatric oncology is important, and we really feel as a community, working with ASCO and the Cancer and Aging Research Group, that geriatric assessment should be incorporated into the clinical care of older patients with cancer.